Well, this is a perimetry quiz, and the idea here is for me to just show you some mystery fields. And you stare at the field, pause the movie, and make your own interpretation, and then I'll go through and tell you what I think I'm seeing in the field. Hopefully we'll teach you some artifacts that can really trip you up in making a diagnosis and show you some other interesting fields. So here's the first one, and let me know what you think of this field, or let yourself know since I can't hear you. So this is a superior arcuate scotoma encroaching on fixation. You can see the blind spot here, this scotoma that is right up to fixation, very low threshold right there. Some people call this a Derringer scotoma because it looks like a little pistol. And anytime you look at a field, you should ask yourself, does this follow the nerve fiber layer pattern? And certainly this does. So this is pretty typical of what we would see in glaucoma, and particularly in glaucoma that occurs at normal pressures. But it can occur at high pressures as well. What's your diagnosis here? So this is somebody who's had a cataract extraction. If you look at this visual field here, you can see that it's diffusely depressed, and that shows up in this mean deviation plot compared to normal fields. But there's, in the pattern standard deviation, there's really no focal defect suggestive of glaucoma. And then as you when we take the cataract out, this all goes away. But you can see that the pattern standard deviation has been normal all the way through. This is a rim artifact, and you can tell it's a rim artifact because there's this steep drop off. Here you can see 29 decibels, it drops off to less than 0. You can also see that it doesn't follow the nerve fiber pattern at all. It crosses the midline here on the nasal side. Usually these are people with plus refractive errors, like this aphakic patient. You can see he's a 14 diopter hyperopic correction. And in this case, the rim artifact goes all the way around. Sometimes you'll see this as if the patient's falling asleep and not being observed. As they back their head out of the perimeter, they'll pick up the rim of the corrective lens. So this is a posterior subcapsular cataract. There is generalized depression, as you can see here in the total deviation map, but it's more central than diffuse. So you can see selective central loss from lots of things, including macular degeneration, of course, and sometimes from glaucoma, but it's an uncommon glaucomatous field pattern. Well, this is a classic cloverleaf field from false negatives. You can see that the patient responded to the 4 cardinal points and then stopped responding to the field examination. This is something you usually see in people who are tired or elderly, and this is not an interpretable visual field. So this is a subtle case of false positives, and one thing I want you to remember is whenever you see this disconnect between total deviation and pattern deviation, where the total deviation is normal and the pattern deviation is abnormal, that usually goes along with false positive responses. And this is a relatively subtle case, but these are the ones that get sent in saying, well, there's this inferior arcuate defect. This is not a defect, this is an uninterpretable field. This is a more dramatic example. Again, normal total deviation, really abnormal pattern deviation. And there are even these little white spots here where the patient has unimaginably high sensitivity. So this is, again, an uninterpretable visual field. So this is a dense superior arcuate scotoma. It follows the nerve fiber layer beautifully. It respects a horizontal. The patient has excellent performance, no false positives or false negatives. You can see the gaze tracker here looks really good. Pretty classic glaucomatous field change. Well, the first thing you notice here is that the printout looks different than usual. That should always clue you in to maybe this is not a 24-2 or 30-2 typical field. This is somebody who has extensive visual field loss, so extensive that we're only measuring the central 10 degrees. So you can see that this is not a 24 or 30 degree field, but only 10 degrees, and we're using a large target. So this is end stage glaucoma with just a very minimal field remaining. So this is, again, pretty typical cataract field. It could be anything that causes diffuse depression like corneal edema or meiosis, but typically we see this in a cataract field. The total deviation, which is comparing this patient to other 82-year-olds, shows that this patient is depressed compared to his or her peers, but there are no focal defects from glaucoma or other focal disease. So this is a learning curve, and what you see here in the first field is the patient has a lot of visual field loss, but it doesn't really fit any pattern. You could say, well, it could be a rim artifact, and that's possible, although it doesn't really drop off to zero here. It's just kind of randomly depressed, and when the field is repeated, the patient gets better and has a much more normal field. One of the real problems we have in perimetry is that sometimes the first field is so disorienting for the patient that their performance isn't great. So that looked like a superior arcuate scotoma in some ways, except the main question you should ask yourself, does it follow the nerve fiber layer? And no, it doesn't. The nerve fiber layer doesn't splay out like this. And it also doesn't have this funny little dip here. So this is somebody with a lid defect, lid artifact, and then when the lid was taped up and the test was repeated, the exam was completely normal, as you see on the right. As you go through these fields, oftentimes you'll see this. You'll see a patient who has these 2 points that are both markedly depressed. One is 0 decibels and the other is less than 0. So what's the difference? Are those the same thing? And the answer is no. 0 decibels is a point that you actually see. So 0 means that the patient can see the unattenuated light, 10,000 apostilbs. Less than 0 means that the patient cannot see the brightest light that the machine is capable of making. Both are abnormal, but there is a difference between 0 and less than 0. Well, this is a low-hanging blind spot. Blind spot shouldn't be here, and this is because the patient has failed to refixate. So at the beginning of the test, if we test the fovea, they obviously can't test it on the camera, so the machine makes this little pattern down below the patient's fovea is tested here, and then they are supposed to look back at the camera. If they don't, then they do the whole test with a blind spot hanging down here, and that drags less sensitive retina into play, which gives you this kind of a funny defect. So when you see a blind spot down like that and sort of a hard to interpret visual field, you should think about failure to refixate. You only get that on people in whom you're testing the fovea, and we always do because it's the most important point in your visual field. But a lot of people have this turned off, and then you wouldn't really ever have this problem. And you can see here over time this change from normal, and then the test from today where the blind spot is low. And you can also see what that does to both the total deviation and the pattern deviation. So should we be concerned in this patient that there's no blind spot? Does that mean that it's an uninterpretable visual field or poor performance? And the answer is no. The test points are 6 degrees apart, and a small optic nerve, like this patient's optic nerve, can fit between the test points and will not show up on testing. And so if you don't see a blind spot, you shouldn't think that it's an unreliable test. Well, so the answer here again is it's a plus refractive error. So you have a +3 diopter refractive error, then you add the correction for near and are much more likely to get these sorts of rim artifacts. And we've already talked about rim artifacts. So this 27-year-old has had LASIK last year. So why does her field look bad? Why does she have all this area of diffuse depression on total deviation when compared to people of her own age? And the answer is you really need to look at the refractive error, right? She was a -7 myope with a correction for near, so she was tested with a -4 in the past, and she was tested with a -4 now, but she's plano now. And just points out that when you have a field that has changed unexpectedly, you really need to look up here and look at the pupil diameter, look at the refractive error, make sure the patient is compared with people of his or her own age. These are all important things to look at if the field is suddenly different. Well, this is just an evolving superior arcuate defect. This is pretty normal here, just a hint of some field loss up above that's just barely making it in the pattern deviation. And then on grayscale and on pattern deviation, you're starting to see an evolving superior arcuate defect. This is a hard one because I've already said that when you see this difference between where the pattern deviation is more abnormal than total deviation, you should think that this is somebody who is false positive, trigger happy, anxious patient. But this patient is a rock star in terms of taking visual fields. No fixation losses, no false positives, no false negatives. So this is the uncommon exception to the rule that I said about this disassociation between total and pattern deviation. There are people who have vision on the right side of the bell-shaped curve. They have great vision, better than 20/20. And so when they have a field defect, it might show up in pattern but not total. This is unusual. So again, when you see this disconnect like that, it should make you biased towards false positivity. But obviously this is arguing against it. And then you'd obviously want to look at the nerve and look at the OCT to see if this all correlates with this superior defect. So the question here is, why does the gaze tracker down here at the bottom look so bad, and yet we only have 1 of 18 fixation losses? And the reason is because the way that fixation losses are determined is that periodically the perimeter will come back and send a spot of light into the optic, where the optic nerve is. And if the patient responds, that means that the nerve has moved. In other words, the patient has moved their eye. But if there's this large area around the nerve that is non-seeing, we can still fire targets out here and the patient won't respond. So these patients who have large peripapillary atrophy or big staphyloma around the nerve often will not demonstrate fixation losses, even though their fixation isn't that great. So this is a tough one. This is a completely normal field. They do occur. This is someone with great performance, right? No fixation losses, no false positives or false negatives. Everything is within normal limits. You look at the gaze tracker. Sometimes these are the hardest fields to call because we're always looking for pathology. Let me show you some examples of change analysis so that you get used to looking at these. Well, this is probably cataract because the mean deviation is going down, meaning there's global loss in the visual field, and yet the pattern standard deviation, other than this one outlier, has remained perfectly flat. That means somebody who's getting global loss without focal loss is probably cataract. So both the mean deviation and pattern standard deviation are getting worse here. This is unfortunately probably worsening glaucoma. These little S's, by the way, just mean that it was a CETA field. This is an older field from before CETA existed. And in the old full threshold fields, we would calculate a short-term fluctuation and use that to come up with a corrected pattern standard deviation. But you notice that we don't get any of that with CETA. So these two blocks we never really pay attention to anymore. This is just a really good example of somebody who's getting worse from cataract. Cataract's taken out and the mean deviation goes away and is normal. And throughout the whole experience, there's been no change in pattern standard deviation. So this has both loss of mean deviation and pattern standard deviation. The mean is more rapid than the pattern, which may mean that there's both cataract and glaucoma, but this could all be glaucomatous loss. Well, this is just wildly variable. It'd be really hard to pick up any meaningful change in this patient because they're all over the map at every occasion. And in this patient, we see somebody whose mean deviation is getting worse, farther from zero. But the pattern standard deviation is turning back towards zero. And the question here is this a good thing? Is the patient getting better? And the answer, no, it's a really bad thing. If you think of what the pattern standard deviation is telling you, it's telling you that there's a difference between point and neighboring points. And so in this patient, there are some areas here that are relatively light, but as those go away, the difference between one point and its neighbors becomes less and less. And so when you see a picture like this, where this is very bad and getting worse, and the pattern standard deviation is creeping back up towards zero, that means that this person is losing the only normal parts of their field. And eventually it'll go back up, never to zero. It goes up to to 1.67. So you can figure that out by turning on the perimeter without having a patient in there. I don't know why it doesn't go back to zero. But obviously in somebody with complete field loss, there is no difference between points. And here's the last one. This patient has 5 out of 6 fixation losses, 33% false positive errors, 21% false negative errors. You can see the gaze tracker is all over the map. Is this a real defect? And the answer is that while this is a terrible field, and the patient's not good at taking fields, he didn't make up this defect. This is real. This is a very classic superior arcuate defect. What it does mean is you don't want to use automated perimetry looking for subtle changes in the visual field when the patient is such a poor field taker. You do hope that if this is the first field, that there will be some learning effect and they will become better and better over time. So this is just a bunch of fields just to make you think about how to interpret a visual field and to show you some abnormalities that are important to recognize in terms of pattern recognition. Just in closing, a lot of looking at fields is pattern recognition. Fields you just look at from across the room and you know what's going on. The sudden drop off to less than 0 that doesn't follow the nerve fiber pattern of somebody who's got rim defect. The cloverleaf field of someone with excessive false negative responses, an unreliable field. The most common one in my experience is disconnect between total deviation and pattern deviation that signifies excessive false positives. You can see this as soon as you walk into the room. It should alert you that this is probably not a readable field. And less commonly, the drooping blind spot, or you might have a superior arcuate scotoma that sits below the horizontal. Instead of on the horizontal, it's down here, signifying someone who failed to refixate back towards the appropriate fixation target. So hopefully this has been a helpful exercise to you to start thinking about how to look at visual fields.